of choice for the strong alloidosis and what is the mechanism of that drug? Ivermectin is the one, but two questions can come from the topic of strong alloidosis. What are those infective larvae? What are the non-infective larvae? You need to remember, rhabditiform larvae are non-infective, filariform larvae are infective is what need to be remembered. Auto-infection, another classical feature of the strong alloid is Stercoralis. And ivermectin is the treatment of choice. Basically, glutamate gated chloride channels in that parasite, they are inhibited by this ivermectin. So that is the reason you need to remember glutamate and ivermectin are closely associated. Let's go to the next question. Hereditary spherocytosis. Is it immune hemolysis or non-immune hemolysis in hereditary spherocytosis? Non-immune. That's the reason in a patient with hemolysis with splenomegaly, a small baby with hyperbilirubinemia, if Coombs is positive, you should not consider or entertain the diagnosis of hereditary spherocytosis. Is the golden rule which you should not basically forget. What is not a major Jones criteria? Now let us take this quiz, doctor. Carditis typically seen in 40%, most common feature. Cardiomegaly, new murmur, CHF, pericarditis, all these are the features. Similarly, migratory polyarthritis, it is found in about 75% of the cases in some of the statistics. And subcutaneous nodules, Ashkoff bodies are seen in 10%. They are found on the extensor surfaces is what need to be remembered. Erythema marginatum is serpiginous and it will be long lasting. Sydenham's chorea, otherwise called Saint Vitus dance, is the rarest feature, but it is the most specific feature is what need to be remembered. And it will be delayed for about several months. And one classical feature of the Sydenham's chorea. What happens to the chorea when the patient is sleeping? It disappears. So it will cease when the patient is sleeping. That is a classical feature of the Sydenham's chorea is what need to be remembered. Now what are the minor criteria, doctor? Arthralgias, fever and any previous history of ARF. And laboratory findings, acute phase reactants, ESR and CRP, and prolonged PR interval on ECG. Evidence for the group A streptococcal infection, that is all very important. What is in hypertrophic pyloric stenosis? You find hypochloremic metabolic alkalosis. Now crusted scabies, Sarcoptes scabies, ivermectin we use, no? It acts on what? GABA, that is glutamate, that is GABA is the one on which it will be acting is what need to be remembered. Now which is the photosensitivity rash that you come across? Porphyria, in the case of DLE, SLE, but not in the case of the lichen planus. What is lichen planus, doctor? Wickham's striae, where on the buccal mucosa you come across interlacing white lines is what need to be remembered. Small flat topped polygonal violaceous papules which are very fine. These are all very classical on the surface. One of the classical description which is going to come in your tomorrow's exam. Polygonal, flat top, chloritic, violaceous papules, where do you come across? They are found in lichen planus. Where do you see Herold patch? You come across in Pityriasis roseae. Oval Herold patch will be found on the abdomen. It is followed within a few days by the development of a generalized rash. Is Pityriasis roseae is any pre-malignant condition, doctor? Generally it is a very benign but very itchy and a very scaly lesion found between 10 to 35 years. So this is a classical example of that oval Herold patch which is developing within 1 to 2 weeks. This individual is going to develop a lot of small pink patches over the trunk, arms and legs is what need to be remembered. Where do you come across anti-DS DNA, doctor? Smith antigen and the anti-DS DNA are virtually diagnostic of SLE, whereas ANA is a screening test, DS DNA is specific test is what I want to underscore to all of you. HIV affects the CD4 cells. Which is the longest acting local anesthetic, doctor? Bupivacaine. One of the common questions asked in the entrance is, which are amide local anesthetics and which are ester local anesthetics? Please remember, lidocaine, mepivacaine, prilocaine, bupivacaine, etidocaine, dibucaine. What is the specialty? There are 2 I's in each of them. So there is no single I. Everything is having lidocaine is Li and Cai. Mepivacaine is 2 I's, prilocaine has 2 I's, bupivacaine has 2 I's, etidocaine has 2 I's. If 2 I's are there, it is amide. One of the ways you can remember. Only one single I is there, that is tetracaine, procaine, chloroprocaine, cocaine and benzocaine. they are all basically ester-based local anesthetics. One mark is there in your pocket, doctor. Then which is the inflammable general anesthetic, doctor? Typically ether. And malignant hyperthermia, hypo or hyper? Hypertension, not hypotension is found. So basically what happens in malignant hyperthermia, doctor? There is one more syndrome called neuroleptic malignant syndrome, which you should not forget. Whenever you use the phenothiazine group of antipsychotic drugs, there can be a development because D2 receptor blockade can predispose to the development of neuroleptic malignant syndrome. Now what are all the clinical features that you come across? Diaphoresis, dysphagia, tremor, incontinence, coma, a very labile blood pressure, pallor, dyspnea, rigidity, hyperthermia, tachycardia, shuffling gait, all these things are found. Now, what is the closest differential diagnosis for the neuroleptic malignant syndrome, doctor? There is something called serotonin syndrome. Did you come across it? Whenever you are using a selective serotonin receptor uptake inhibitor, then SSRIs, such people can develop it. So there will be altered mental status, autonomic dysfunction will be there, neuromuscular abnormalities will be there. So there are all the features in the serotonin syndrome, which is the closest differential diagnosis for the neuroleptic malignant syndrome. So it is not hypertension, you are all hypotension, it is hypertension is what I want to underscore. Now in general anesthesia, what is first affected? Myelinated or unmyelinated? Myelinated. Which is myelinated between these two? Pre or post? Preganglionic sympathetic fibers. Dissociative anesthesia is seen in the case of the ketamine. Then what is the early feature of the ulcerative colitis on barium enema, doctor? Loss of those hostrations. So this is a supine upright plane radiograph. What you can see is here the descending colon, you can see that generally the hostrations which you are finding here, they are lost. So loss of the hostrations is the earliest feature of the ulcerative colitis, is something that should not be forgotten. And also you can see that there are a lot of polypoidal filling defects which are seen, in the case of the ulcerative colitis, another classical feature. And the thickening of the wall of the colon because of the presence of the edema of the wall, otherwise called the thumb printing sign, is another important feature which is seen in the ischemic bowel disease. Also thickening of the wall of the colon because the edema is also seen in the case of the ulcerative colitis, is what I want to underscore to all of you. What is the gold standard for the extrahepatic biliary atresia? So please remember, is it liver biopsy or cholangiography? There is one special way of doing cholangiography in the extrahepatic biliary obstruction. It's called intraoperative cholangiography, whereas preoperative is not really going to yield a lot of information. Liver biopsy is considered to be the gold standard, is what need to be basically remembered. What do you mean by biliary atresia basically? It is the obliteration of the extrahepatic biliary system that will lead to obstruction of the flow of the bile, and it is the most common surgically treatable cause of the cholestasis in a newborn child. Tomorrow, this is a question that is going to come in your exam. Most common surgically treatable cholestasis in the newborn period is because of extrahepatic biliary atresia. Doing the hepatobiliary imaging can be wonderful screening test. For that, which is the radionuclide scan that you will be using is going to be a question. Technetium labeled diisopropyl imidodiacetic acid called DISIDA scan is the one which you can use for identifying and only screening, not a gold standard. And ultrasonography can exclude the other abnormalities but can't prove the extrahepatic biliary atresia. Especially what is the closest differential diagnosis which also can lead to the development of the cholestasis in the pediatric age group, Dr. Cholidocol cyst. So that can be eliminated by doing the ultrasound. So that is the reason. And one more thing is intraoperative cholangiography, not preoperative. If you do that, then definitely demonstrates the anatomy and the patency of the extrahepatic biliary tree. On any given day, percutaneous liver biopsy will be a most valuable study for evaluating the neonatal cholestasis, is what I want to underscore to all of you. Let's go to the next question. Radiolucent kidney stone, which is the one? Urate stone. So there will be radiolucent. If you do an excretion urogram, it will be like a filling defect, and sometimes it can be mistaken for a transitional tumor of the upper urinary tract. So all these things you have to basically remember, doctor. And what is the predisposing factor for the development of these urate stones? A low pH or a high pH of the urine? A low urinary pH. Any condition leading to hyperuricosuria. Anything that has decreased the ammonia excretion All these are the important risk factors for the development of the urate stones. Obviously, if ammonia excretion cannot be done, H plus ion cannot be buffered. If it can't be buffered, then the urinary pH become low. If it has become low, it will precipitate the urate stone. So this important relation need to be basically remembered. Now how do you want to treat the medullary carcinoma of the thyroid? So is it total or hemithyroidectomy? So you must be doubly confident about your answer. Whenever there is a palpable thyroid nodule, do a FNAC, and then if it is proving that it is medullary thyroid carcinoma, perform a total thyroidectomy. Now the next question that can come, a little higher level question, if the examiner wants, is if the regional lymph nodes are having a microscopic invasion in a given case of the medullary carcinoma of thyroid, then what do you want to do? Then you do a central neck dissection and you try to remove the node-bearing tissue between the hyoid bone and the innominate vessel sternothyroid. In all these areas you remove it. And is there any role for inferior parathyroid gland which can become damaged while you are doing such an extensive medullary carcinoma of thyroid total thyroidectomy surgery? Definitely. This inferior parathyroid gland need to be autografted in the cancer-free zone under the sternocleidomastoid or the forearm is the major part of the management of medullary carcinoma of the thyroid. And what is the oncogene that you want to screen, doctor? Ret proto-oncogene and MCT need to be basically remembered. Where do you come across basal ganglia calcification? Hyper or hypo? Both hyper and also hypoparathyroidism. And is it pseudo hyperparathyroidism and the pseudo hyperparathyroidism? Do you come across calcification? Very much you can come across. So hyperparathyroidism, hypoparathyroidism, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, in all these conditions you can come across the basal ganglia calcification is what need to be remembered. And mitochondrial cytopathies, hypothyroidism also you can come across. But very important is that starch group of infections are there, no? Their basal ganglia calcification should not be forgotten. And tuberous sclerosis is another condition where there will be subungual fibromas, development of basal ganglia calcification with the development of typically in tuberous sclerosis seizures. They are all the classical features. Now that's the reason whenever there is a basal ganglia calcification, not always you come across a calcium abnormality. It can occur without calcium abnormality also in the infections is what I want to underscore to all of you.